David, thank you very much indeed. So my get-up will indicate that we are serious about this. So we're serious about smoke. And exactly as surgeons, that is what exactly we got to do. So we got to realize early in the part of the COVID outbreak that basically it is tough, and we've seen and we've been talking to many of our colleagues across Asia, and they were kind of looking for answers and real answers that we weren't even sure of. So we tried to come out with something that could help not only the community in Singapore at large, but also across Asia, and help them practice safe MIS surgery, because there was a lot of concern around minimal invasive surgery, smoke, and COVID time. So basically what we would do is I'll just bring you through the paper itself and the guidelines which we wrote. And this was vetted by all the 50 board of governors, about 56 board of governors from different societies across Asia, and approved by them. And it has been translated into multiple languages, and they are available on the ELSA website should anybody need to make reference to it. So these are basically not only references to as just to how to practice during the days, but it gives you a community-wide spread in pandemic. So whether you're high in pandemic spread at the moment in your community versus low, so we've tried to pin it down to a centered approach in that way, from widespread to recovery phase in our list. So as I said, the overarching principle of these guidelines are just meant to guide people. The overarching principle is that one should use them judiciously and make use of clinical judgment more than anything. And they are written considering the fact that the disease would either be widespread in the community or there would be limited spread in the community. So if you look at these columns, on the x-axis here, you will see case selection for elective cases and screening elective cases, whereas on the y-axis here, you will see with differential in color. This is peacetime in green color. Isolated cases, which currently is what Singapore is going through. There are those communities which are recovering and have limited community spread. And a while ago, we were in active community spreads, as you saw in UK, US, currently going on in Bangladesh, Pakistan, India, Sri Lanka, and many other parts. So when it is red, you only do elective case, emergency cases. However, where we are in Singapore, we can proceed with all elective surgery, considering delaying non-urgent surgeries. Like at the moment, we don't do those many bariatric surgeries. The hernia surgeries that really need doing are the ones that we do. And basically, when we are going to do cases from the community, in this, we do not really test our patients for COVID. Whereas if there is limited community spread here, we wait for elective cases, test our patients for COVID by doing swab, generally 48 hours before surgery. And for those who have a higher exposure, maybe even doing a serology for them. Yeah, so this is what we are doing, and we screen them through history in Singapore as we are concerned. We have selection criteria for emergency surgery. Where preferable in the red and the orange zone, we manage them non-surgically, like acute cholecystitis with antibiotics. However, should there be failure of therapy, then there is no choice, and under stringent conditions, as I would go through the guidelines, you can manage them. In isolated cases, there is routine management as emergency cases. So PPE requirements, even in this time, we still stand at full PPE for COVID-19 positive or suspect cases. Cases which are not suspect do not require physicians or surgeons to wear this. There are other safety guidelines that we have put in place. What we have learned is that high-risk surgeries like intubation, like endoscopies, head and neck surgeries, the plastic oromaxillofacial, where the likelihood of contact with secretions containing COVID is higher, we will continue to maintain PPE in this. And this is how we translate our recovery phases to this. So reopening strategy, active community spread, please do not start back clinical services. When it is limited spread, you can take back your oncology services, and the reasoning behind that is if you leave them, then they would either progress to more advanced disease and they would lose the window of opportunity. And other essential services like trauma and obstructives, which cannot be delayed, need to continue. When we go to isolated cases, we restart our day surgery short stay cases, and when we come to a blue or green, we go and resume benign surgery back. So guidelines in general surgery are, first of all, if you're operating in a high zone where there is high spread, or the patient is doubtful, is a suspect, then you should warn the patient of COVID-19 infection in the perioperative, i.e. post-operative period, and that the outcomes of surgery may not be very good, given it be elective or emergency surgeries. Try and avoid after-hours surgeries and choose skillful people to do these suspect cases rather than having to train trainees on them. During intubation and extubation, depending upon the numbers of cycles at which the air in the OT is renewed, you can basically ask your non-essential people to stay out of the OR a minimum of 5 minutes. I think NUH has about 20 exchanges of gases in 1 minute, and within 5 minutes, the entire OR is completely clear off. Now, if available for positive cases, then you use an OR which is negative pressure, which means air is being continuously sucked out, or you choose an OR which is separate from the main OT complex, or at least a corner OR which is separate. PPEs for us include an N95 mask, and I think impervious gown, double gloves, shield, goggles. I think a lot of people are going for some hoods. There are others with clear space. So you can use them for suspect or for your confirmed cases. Regional anesthesia where possible as compared to general anesthesia. I will not talk much about surgical Plume. I will leave David to talk about surgical Plume. The third thing we wanted to emphasize was effective communication. There's no alternative. Then dispose your waste carefully, and educating your staff, allied healthcare, your colleagues and others is of key essential in helping and protecting the environment and the surgeons. As far as minimally invasive surgery is concerned, we need to weigh the risk and benefits of approving a surgical procedure. Does delaying make it any more dangerous to wait, or operating weighs heavier as compared to the risk? So it's a personal choice. It's a decision you make with all the knowledge you have for that particular scenario. When we insert the trocars should not have an air leak. Purse string sutures or disposable trocars with skin blocking systems should be used, like those that have balloon at the end or are ripped. They will prevent escape of air, and disposable trocars are preferable over reusable trocars because of the risk of contamination with virus and the effect that we wouldn't be able to clean them. So these are among the first guidelines that have come out for Asia as such. So we talked about pneumoperitoneum, and we should create a safe pneumoperitoneum, one that the surgeon is familiar with, and we should use a filtration system. I will leave it to David to talk about the smoke and filtration. And two-way pneumoperitoneum, blowing with two insufflators is not a great idea because the virus will colonize the circuit. Teach and practice safe surgery. Plume prevention. So I would just say we minimize the use of energy devices, suction frequently, and keep instruments, and try and do a bloodless surgery. As I said, I would try and keep away from smoke because David is going to smoke it. So I'll go on to instrument care. So where possible, use disposable instruments for patients. You do not want contaminated instruments to be used. Reusing disposable instruments, firstly, disposable instruments are disposable and they shouldn't be reused, but we know in many Asian countries we still reuse them, so we strongly discourage them. The reusable instruments, obviously the concerns about reusing them is decay in their quality, inefficient sterility, and equipment failure. When we use instruments, sharp instruments especially, they can breach the gloves. Just simple things like A laparoscopic hook can break the glove, so we need to be careful. Surgical drainage only as clinically indicated. Just because the patient is COVID or has something, please do not insert drains. Well, I think that's all I have. I would like to thank you, and I will hand over the mic to David. David?